All right, well, I think we'll get started and let people just kind of trickle in during the introduction. So hello, everyone, and welcome to PGTME's fifth annual Lunchtime Lecture Series. My name is Aiden Ilmus. I am the program coordinator of PGTME, and our moderator and panelists will be introducing themselves shortly. We're so grateful to have you all here for our fifth year of hosting this event. We are always impressed and inspired by the diverse group of attendees and thoughtful engagement. PGTME is a project of the Division of Medical Ethics housed in NYU Grossman School of Medicine's Department of Population Health and funded in part by a gift from Parent Project Muscular Dystrophy. You can learn more about PGTME on our webpage. I will drop a link to it in the chat in a moment, and also information on how to join our mailing list to receive our quarterly newsletter and keep up with our work. We're very excited to hear from the speakers for today's panel, Ethical Questions in Genetic Screening and Testing. If you are unable to attend any of our talks, we'll be posting captioned recordings once the week is concluded, and we'll share those links with all registrants. Today's event will feature brief introductions by our panelists, followed by a moderated discussion. We've also allowed at least 15 minutes for audience Q&A at the end, and we encourage you to submit questions throughout the hour using the Q&A feature. So without further ado, I'm going to hand it off to our moderator, Holly Tabor, who is director of the Stanford Center for Biomedical Ethics, to introduce herself and the rest of the panel.
Thanks, Aiden. As Aiden mentioned, my name is Holly Tabor. I am the director of the Stanford Center for Biomedical Ethics. I'm also a professor in the Department of Medicine and by courtesy in pediatrics and epidemiology and population health at Stanford. And it's my great honor to be here today with the PGTME, who does amazing work and are really wonderful panelists. It's a very important topic, and we have wonderful people to speak with us today and share their expertise and experience. My work, in part, has focused on ethical issues in genetics at a variety of levels that are relevant to this work today. I've done some work on return of results from genetics, from genome sequencing, both in a research and a clinical context, and thinking about how people understand results and how they think about their expectations and the meaning of results after they get them. I've also done some work on gene-targeted and gene therapies and how different patients perceive the risks and benefits of both participating in research about gene therapies and gene-targeted therapies, but also what their hopes and aspirations are for how it might affect their quality of their lives. And then currently, I'm the co-principal investigator at the Stanford Undiagnosed Diseases Network Center, where we think about a lot of issues about both diagnosis and diagnostic and therapeutic odysseys, but also equity issues related to diagnostic journeys for people. So all these experiences make me very, very interested in hearing and discussing this with our panelists today. I know we have a lot of people here from a lot of diverse backgrounds. Some people are perhaps experts in the topic. Some people at one end of the spectrum. Some people may be experts in the ethical issues involved, and some people may not know as much, may perhaps be patients or people who are on their or their own family members' diagnostic or other odysseys and things and journeys. So we're going to try to address all of those things and all of those audiences today and how we talk. I think this topic is really important just to provide a little framing, because when we think about gene therapies and gene-targeted therapies, we need to be able to identify the people who can benefit from those gene-targeted therapies. And to do that, we have to be able to accurately diagnose people and test them. And genetic testing, as many people here probably know, occur at a variety of different time points. Sometimes genetic testing happens when you have a diagnosis, perhaps a certain kind of cancer, and you're trying to understand if you have a genetic causal factor associated with it. Sometimes genetic testing happens when a family member receives a genetic diagnosis and you want to understand the risk of a family member. There are children who sometimes, for example, in the Undiagnosed Diseases Network, have an undiagnosed condition, and genetic testing and genome screening are used to try to understand what's causing their condition. And then at newborn testing, whereas both classical newborn screening, which we're going to hear about today, but also newborn genome screening to try to identify patients and conditions at the earliest points in life. So we think about genetic testing, with screening, return of results in a variety of ways. And today we have some amazing panelists who are going to talk to us about different perspectives on genetic testing, screening, return of results, and the ethical issues involved. So I really hope we'll have a lively discussion. What we're going to do first is have each of our panelists briefly introduce themselves, and then we're going to have each panelist talk for a little bit, and then we're going to come back and have some questions together. So if you have questions or concerns, if you could put them in the chat, that would be great. And without further ado, I think I'll first pass the mic to Stephen, to Dr. Kingsmore, to ask you if you would like to introduce yourself and your background.
Sure, thanks. Nice to be here. My name is Stephen Kingsmore. I'm the president and CEO of Rady Children's Institute for Genomic Medicine, which is a young research institute affiliated with Rady Children's Hospital in San Diego, California. We focus very heavily on this area. We decode genomes of thousands of children a year, both for genetic diagnosis and for newborn screening. So I look forward to sharing some of that experience with you today.
That's wonderful. Thank you. Aiden corrected me. If you have questions, please put them in the Q&A function. I just wanted to clarify that before I pass the mic to James Griffin. James, would you like to introduce yourself?
Yes, I'll be honored to. Thank you for having me. I'm James. My name is James Griffin. I'm a sickle cell advocate. I was diagnosed with sickle cell at the age of 2. I'm also a published author with the book about sickle cell, and also I'm a rare disease legislative advocate who continues to advocate for rare diseases to have access, treatment, care, and advocate for sickle cell, people who live with sickle cell.
Thank you, James. And I recently had the honor of reading James's book, and I plan to use it in some of my teaching. So I really recommend it. We'll put the link in the chat. And then I'll pass the mic to Dylan Simon. Go ahead, Dylan.
Hi, my name is Dylan Simon. I am the Senior Director of Policy at the EveryLife Foundation for Rare Diseases. We're a nonprofit policy and advocacy organization that focuses on the broad rare disease community and working to develop policies and support policies that support the development of and access to rare disease therapies and diagnostics. And so the diagnostics portion is what brings me here today. Done a good amount of work within diagnostics and genetic testing, as well as newborn screening. So happy to talk more about that.
Thank you. And again, I'm so excited to have all of you here. I think you represent a really wide range of important experiences and perspectives, and we're really looking forward to hearing them and combining them together. So without further ado, Dylan, I think I will pass the mic to you first to give your presentation, talk a little bit about what you do and about the what you think about in terms of the topics that we're going to be addressing today. So Dylan, why don't you take it away?
Yeah, happy to start. So as I said, I work at a rare disease organization. And so for us, the diagnostic odyssey is a huge part of the rare disease community. And for those who don't know, it takes on average just under 6.5 years to receive a diagnosis from onset of first symptom within the rare community. And so that odyssey is a huge part of the community. And so that's why it's a key part of all of our work. And how can we identify ways to bring down that delayed diagnosis and ensure timely diagnosis? And we know that timely diagnosis not only helps from a healthcare perspective in terms of it's always better to get diagnosis earlier, but we also have been able to show that it has an impact from a economic perspective. And Ian just dropped in the chat our delayed diagnosis study that showed the impact in terms of providing a timely diagnosis does save a fair amount of money for the healthcare system. And that's because we know that it cuts down on number of interactions with the healthcare system as a whole. And so if you think of it from one specific area, we have been able to find in a previous study that on average, individuals during the diagnostic odyssey will have approximately 2.5 out-of-state visits to obtain their diagnosis. If you can cut that down to, in a perfect world, none, but let's assume one. Let's assume you have to go to some sort of center of excellence to go receive your diagnosis. Well, even that, just going from average 2.5 to 1 out-of-state visit, you're really cutting that down. And we know that genetic testing can play a huge part in that process. And so for us, it's always looking at how can we increase access to genetic testing, and also recognizing that there are going to be kind of two different avenues. Because many within the rare disease community look to newborn screening as a great option to provide timely diagnosis because it is done at birth, and you typically will get a diagnosis within the first month of life. And we know that for many rare diseases that are genetic in origin, that degenerate by nature, providing that early asymptomatic diagnosis can play such a huge role. We also know that not all rare diseases are set up to be added to newborn screening. I'll talk a little bit more about that in a moment in terms of what's looked at within newborn screening. But in those situations, if it's not ready for newborn screening, we still want to ensure the fact that there is broad access to genetic testing because the cost has come down, the medical evidence has gone up, and we still see spotty coverage for genetic testing across the country, both across public and private payers. And we know that we do see it. Gene panels, you're seeing more coverage for, but we know if you're looking at newer technologies such as whole exome sequencing or whole genome sequencing, coverage is spotty, reimbursement is spotty, and that says nothing of prior authorization, which is a whole other situation and another headache for those who have to go through it. But today I want to focus a little more around the newborn screening side and that relationship to genetic testing. And so for a condition to be added to newborn screening, it's looking at a variety. It's really kind of into 6 main areas, but it's really kind of down to 2. Can you screen for it in the general population? And do you have a treatment or care standard available? So breaking that down a little further, there is a federal RUSP or Recommended Uniform Screening Panel, and I'll go a little sidetrack here in terms of that R. It's always important to know that R is recommended, not required. States have final say on what conditions they screen for. And so the federal government will make a recommendation and states tend to follow it. How quickly they adopt a new condition will vary based on the state. Some of those variations I think are quite predictable in terms of size of the state, funding for public health within the state. Those tend to be kind of how you can determine which states tend to adopt faster or not. But when looking at it for the RUS, they're looking at in terms of screening potential. Can you screen for in the general population? Because newborn screening is a mandatory screen, which it currently is, and for the foreseeable future will still be. And they want to ensure the fact that you can screen, that you can have a good false positive rate, and you're properly conducting these screening tests. And so you'll often see pilot studies, generally that have been viewed as kind of smaller citywide pilot studies have been enough. Recent evidence shows that the Federal Advisory Committee is seeking more statewide data, which is a whole other conversation, which I'm happy to have on another day. But from the screening side, what they're looking for is, does the screen work, and can we do it in a general population? And so more typically right now, the testing is metabolic testing. Tandem mass spec is used for 36 out of the 38 core conditions on the federal RUSP. And that is what is currently done. And it's also important to note a key part of the evaluation for addition to the RUSP specifically, but as well as every state, is what is the capability and what is the ability of the lab to actually conduct this screening. And so as we start having conversations around how we implement genetic testing into newborn screening, that's going to be a huge conversation, because currently these state public health labs are geared towards metabolic testing. And if we're going to switch to more genetic testing, obviously it can be done, but that's going to be a scaling question, something that has to be looked at. The other aspect is also around treatment. And so to be a newborn screening condition, currently, you need a treatment or care standard. Very specifically, does not need to be an FDA-approved treatment. I always want to make sure I say that pretty early in that, because the first newborn screening condition, PKU, does not actually have an FDA-approved treatment, but it has, if you follow a medical foods diet, the onset of conditions does not occur for a PKU patient. So you can have that care standard, which is why you see a lot of metabolic conditions on newborn screening panels. But you can also as well have an FDA-approved treatment. And the reason for that is the current ethical guidelines around this is, if we're going to have mandatory testing, and if we're going to provide this early diagnosis, we should also be able to do something for the family. That is a larger conversation that conversation will continue to grow as genetic testing and newborn genetic testing grows in its capabilities, and it's as we recognize that we can start providing diagnosis for many more conditions, and whether or not that should occur is a interesting ethical conversation, and one that we're always happy to have. And so what will happen is, if it meets the certain conditions, it'll get added to the federal panel, and then states will make their decision. Some states will move faster than the RUSP, but more often than not, states are adding conditions once they're added to the RUSP. And that can typically occurs within the newborn screening program. They're the ones making the decision. but it also flags some of the policy concerns moving forward around integration of genetic screening in the newborn period. Is how do we look at the adding of these conditions to state panels? What are the challenges there? There is a large conversation around informed consent, what is and is not possible currently within newborn screening. That is mandatory test, and it is an opt-out system. In addition, the dry blood spots are stored within the state public health lab, and they are viewed as de-identified biospecimen, therefore do not require informed consent. However, there have been a couple of lawsuits that are challenging this issue. And so those are some of the policy issues that need to be addressed. In addition, how data gets shared can be a challenge in terms of how to identify best practices, how to share what works best. A key part of the onboarding process in any state is optimization of the test for their state. Is there a way that we can make that easier and make that more efficient by allowing for states to better communicate in a more official fashion? Because currently we know that they are communicating. State public health officials are always having to pick up the phone and call their colleagues, but is there a way that we can make this a little more efficient? And so those are some of the policy issues addressing it moving forward, that in terms of genetic screening, and kind of happy to talk more about that as well. But I think I have reached my time, and with that, I'll pass it back to Holly.
Great. Thanks, Dylan. That was very interesting. I'm already thinking of several questions that I hope come up in our Q&A. Thank you for that. I think next we'll pass it to Stephen. Stephen, I was wondering, can you want to take the mic and give your presentation?
Sorry about that. A few technical difficulties. I'm going to share my screen.
Great.
Sorry about this.
No worries. Thumbs up.
So let's talk a little bit about scaling genetic diagnosis. Make it a little bit smaller. So Dylan mentioned this, that the current situation around the world is quite horrible, that children wait years before a diagnosis is made for their genetic condition. And furthermore, it's a highly inefficient process and highly inequitable. It increases inequity in terms of healthcare provision. Let me just look with you at an example of what we're talking about. This is a little girl. She arrived in our emergency department a couple of years ago on a Sunday evening, with mum saying she could not put the baby to bed. When the baby was examined, it was noted that she had mild encephalopathy. And so a brain scan was ordered. It's shown on the right in panels A through C. And those white fluffy lesions are highly abnormal and suggest that the baby has hypoxic ischemic encephalopathy. The baby didn't, but that's a relatively common condition in newborns. On the right-hand side in D&E are the patient's sister, who had presented 10 years earlier at the same age, same presentation, and same set of MRI images, as you can see. This raised a suspicion that this may be genetic and not hypoxic ischemic encephalopathy. So this is the clinical course of the baby. Admitted, as I said, about midnight on Sunday night after that brain imaging study. And the next day, a genome sequence was ordered, as you can see, around noon. And it was only at that time that that family history became apparent. We just jumped through this, but basically today it's possible to decode a baby's genome in a day. and to return a result back to the caring physicians. And that happened here, and the diagnosis was a rare genetic condition, autosomal recessive biotin responsive basal ganglia disease, and this is eminently treatable. It's treated with biotin and thiamine, 2 dietary supplements. They were started, and the baby recovered and went home. Compare that with the older sibling who went undiagnosed for a year, followed that trajectory I showed on the prior slide, and died of profound epileptic encephalopathy. So this is a relatively new change in medicine, where we've gone from being unable to provide a diagnosis to being able to do it today. The body of evidence that we have accrued as a community over the last decade or more is now substantial and overwhelmingly supports policies for this to be widely covered. You can see there the diagnostic rate, the clinical utility rate, and the fact that this actually saves the healthcare system quite a lot of money per patient tested, so it's net cost savings. So there's really no reason not to have this be broadly implemented. This is the current coverage map of the United States, and you can see exactly what I mean by inequity, that many parts of the states do not have coverage policies. Furthermore, not all the coverage policies are effective. And in fact, the light blue states have policies which are ineffective. They mandate that this testing should be made available. They provide no funding to reimburse such testing. And so obviously in such states, there's a policy, but it's unfunded. Whereas in the other states shown in the darker blue, there is funding. So just shows you how you can have a great technology that can save children's lives. It takes more than a decade to accrue the evidence to support its implementation. And even then we face this real ugliness of inequity. So right now, if I look across the US and say, how well are we doing with this? It's not very well. That adoption is very small. That where the technology is being used is being underutilized, that many neonatal intensive care units and other intensive care units don't use this technology at all. And in fact, the policies, as I've mentioned, often are inadequate and not providing this to everybody who needs it. However, it's not all the fault of policymakers by any means. Physicians also are becoming laggards. In general, physicians don't know how to cope with a genome-based sequencing test. They don't understand the report. They don't understand how to translate genome findings into precision care. And this ties into that diagnostic odyssey, which then becomes a therapeutic odyssey. And I've highlighted in this slide some of the areas where we really need to focus future research to solve existing bottlenecks and upskill MDs. One way we're doing this is with clinical guidance. We can now use things like large language models to start to provide communication with physicians that can help to upskill them. I'm just going to finish with a couple of slides on what Dylan talked more about, which is screening. So screening is totally different from diagnosis. In screening, we're testing an entire population, whereas in diagnosis, we're waiting until a child is affected, is symptomatic, and then individual testing. So the whole paradigm is quite different. The performance metrics are different. And unfortunately, sometimes we confuse them and amalgamate them. So they really are quite different. And because we have a good diagnostic modality, does not mean that we've got a good genome-based screening modality. Tomorrow, we'll publish results of a first clinical trial of our newborn genome-based test for population screening. And so far, it looks really good. It's quite different, as you can see if we compare the three colors down below from traditional state newborn screening and also from diagnostic testing in terms of who it detects and in terms of its analytic performance. We are now one of about 25 or 27 groups worldwide undertaking research in terms of genome-based newborn screening. In total, over 2,000 disorders are being evaluated. Unfortunately, as you can see from the map of the world, again, we've got this unfortunate aspect that we are choosing to focus heavily on Northern European genomes to the exclusion of most of the world. And if you look at the bottom panel, this is more of the world's genetic diversity. And really the populations that are being heavily evaluated currently are some of the least diverse. So we need to pick that up. We need to have many more populations be represented in this. And I think the final note would be, we're still several years from having the type of evidence base I showed you in an early slide about diagnostic genome sequencing. We're just not there yet, but that evidence is being generated currently. Thank you.
Great, thank you. It's very interesting and lots of thought-provoking data. I'm looking forward to discussing that more. James, why don't we pass the mic to you?
All right, thank you. So I'm just going to talk about the way I found out I was diagnosed. My mother and father, they didn't know anything about sickle cell. And so, they went on to have children. I had two older siblings at the time who were normal and healthy, never spent the day in the hospital. And when I was born, my mother noticed some jaundice in my eyes, which is a symptom of sickle cell, can be a symptom of sickle cell. But the nurse reassured her that, everything was fine. It should go away within a couple days, months. It was common in newborn babies. So then one day I'm playing in a room and I let out a loud scream. I'm about 2 years old. My mother runs to check on me. She notices me playing with my other brothers and my brother and sister at the time, and she noticed my hand was swollen and puffy like the size of a tennis ball. After noticing that, she came over, picked me up, tried to console me, calm me down. She couldn't. So she took me to the hospital, and it was during that time they ran different tests like x-rays and blood tests. And this blood test came back that I had sickle cell. And so they didn't know anything about genetic testing at the time. They didn't even know anything about sickle cell. But during that test, after I was diagnosed, they ended up testing my other two siblings and then also testing my mother and father. And they were told that they had the sickle cell trait. And so now they were more aware of having sickle cell or how you can get sickle cell. So I think it's important that, we have things like newborn screening, because when I was born, they didn't have the newborn screening for sickle cell. It came in after I was born. And so my family had no way to prepare for what I was going to go through. I was in and out of the hospital a lot as a child, spent many days to weeks at a time. I had to have blood transfusions. Um, and because of this time spent in the hospital, my mother was the one who had to put her job on hold so she can be with me every step of the way. And this is something that people don't think about when you have a child with a rare disease. The time spent away, the parent has to care for that child, and so it can affect the whole family. And essentially, it did. So my dad had to be the provider and take care of my other three siblings now because they had another child after me. Still not aware of sickle cell, how you get it, but they had another child in who's healthy. But he had to care for the family. And so because I was in and out of the hospital, it took a tremendous toll. Finances was lost because of my mother was not working. So we had a hard time with finances because I'm in and out of the hospital. Just having simple things like medication, the cost of medication was too much for my parents. The cost of some treatment could be too much. So I have to advocate because of the time I spent in the hospital. It's important to me to share my story and talk about why we need genetic testing and access to medication. I also want to talk about why I got involved with sharing my story. And that came at an older age as an adult. I faced stigma. So going to the hospital and needing medication to take care of me, treat me like morphine, Dilaudid, those kind of medications, well, me going in as an African American was seen as drug seeking. So I had to learn how to speak up for myself and talk to doctors and explain to them, no, I'm really in pain. I really need this medication. And so that led me to advocate for others who may be thinking that they have no hope or thinking that they're all alone with this illness, and how can their voice be heard. And so I wanted to speak up and be the one to share my story and explain that we face heavy heavy stigmas because of what we go through, having the pain and being in and out of the hospital is seen as drug seeking, or we call frequent flyers because we're in so much. And so ultimately that led me to want to advocate and share my story. And through the advocacy, I got involved with different nonprofit organizations, which led me to uh, EveryLife Foundation. Now, EveryLife Foundations deal with legislation. And so I think as an advocate, it's important for me to get involved with legislation because legislation is what can make changes, lasting changes when it comes to access or it comes to treatment care or having facilities that want to treat and understand what the rare patient goes through. And so that's kind of how I got involved. And that's why I'm here today to share my story and speak about what I went through and how it affected my family and just not having the resources or the time and to go through that. And I think it's important now that I know we're going to talk about gene therapy. We're going to get into that. I think it's important that we have gene therapy for people who have rare diseases that could cure their diseases, and we diagnose it early on, so that families can prepare and plan. And if you have you have an understanding of what you might face and you see it, then you can prepare for it better, and you can go into gene therapies and handle it more. Because if I was a child and I had options with gene therapy or knew more knowledge about gene therapy, I would have got into it earlier. And so that's where I'm at now, and that's why I'm here today.
Thanks, James. And I really appreciated how you talked in your book also about some of the details of what that experience was like, not being diagnosed and not knowing about it. And then some of your experiences also feeling like you don't get seen and believed, as you talked about when you have crises and pain and you go into the hospital. So that's very powerful and important, I think, for a lot of different conditions and families who are experiencing these. Thanks for sharing that.
Yes.
So I think I'm going to have some discussion now, and I'm going to start with a question for each of you, which is from each of your perspectives, what is or are the most pressing sort of ethical, policy, or operational concerns raised by this discussion? And I think each of you have touched on that a little bit. So maybe I'll take turns passing the mic to each of you. Dylan, I think you talked a little bit about some of the needs moving forward from a policy standpoint, including sort of making states more similar and have similar types of programs. So would you like to go first, Dylan?
I think most pressing, I think it's the ability to add conditions, and that covers a lot, but a key part of that is becoming, because the nature of rare diseases, small patient populations, data collection can be challenging. The low-hanging fruit for newborn screening has come and gone, and working on how to collect data collection processes and what that looks like and what are the requirements for newborn screening, I think is a big policy issue moving forward, because as we develop new therapies or as we develop new screening tools, how do we ensure the fact that we're getting conditions added in a timely manner? And the reason I say that is because there's a condition known as MPS 2 that was added to the federal recommended panel in 2022, and it received an FDA-approved treatment in 20 years prior. And so for 20 years, there was a treatment out there that we knew had that early diagnosis would allow for early treatment would make an impact, but it took 20 years to get the data where it needed to be. And so how do we address some of those issues moving forward?
Yeah, and related to that, there've been a couple questions in the chat that I'll address, but you mentioned that one of the criteria usually for conditions to be added even to the recommendations on a national level that may or may not get adopted is that there be a treatment. And I was wondering if you could talk a little bit more about that. And someone had a question of what's the standard of evidence for a condition to be considered to be treatable? And then I had a follow-up question too, but why don't you go answer that first, Dylan?
Nope. So I saw that question, and that's a great question in Q&A. I would love to give you a more definitive answer and say, here is what actually needs to happen. There is no set you need to prove X, Y, and Z. So there is, at least at the federal process, there's an evidence review group. They collect all the literature and determine what the care standards are. They work with a technical expert panel. And so they're really relying on the literature and what the literature says in terms of if it's a non-FDA approved treatment care standard, and seeing what the literature says and going from there.
Yeah. And I do see there's another question in the chat. Don't worry, we'll get to that. We'll come back to that. Thanks, Dylan. Stephen, do you want to talk a little bit about what you think the most pressing ethical and policy concerns are about screening and testing from your perspective? You talked a little bit about lack of coverage and variations across states, but I'm sure you have other thoughts and reflections on this too.
Yeah, so genome-based newborn screening is still very new. And so there are quite a few ethical concerns. Traditional newborn screening is not consented, so it's done without asking permission or recording informed consent. That will not fly for a genome-based newborn screen. And so that is a sea change. And it raises a whole bunch of issues related to, well, what would that do to standard newborn screening? Could it stigmatize it? Because currently 98, 99% of babies will get a standard newborn screen. We don't want to upset that apple cart. That system works well. It's been around since the 1960s. It's not controversial. Genome-based newborn screening is something new. So there are a lot of issues there, but it's early. In terms of diagnostic testing, the ethical issues relate to the fact that we don't have equity, that we have disparity, that we have populations who just won't get this test. One of the largest reasons for disparity is geographic. If you don't have an academic health center within driving distance, you're probably not going to get these types of tests. And so vast swathes of the US population just don't have access. We also have the issues of policies where, as I mentioned, right now we have this tapestry. It's part and parcel of healthcare delivery in the US that every state has multiple routes whereby you can get healthcare resources. And so it's very complex. Multiple layers of decision. And that kind of means that anything that's new is going to take years to really work its way through the system and into your doctor's ability to actually order that test. And so right now, a number of states have no policies. A number of major private insurance companies don't provide coverage. One that's in the news today does not provide coverage for this testing. And so this also is very concerning. And then the actual policies themselves sometimes are really ill-advised. That Medicaid, for example, does not cover the full cost of a hospitalization of a child. And so the idea that you can mandate a policy to provide something like a genome sequence when already that Medicaid bill is being subsidized by a hospital is not tenable. And that means, for example, in California, where we have a policy. We were the first state to have a policy, but our policy is idiotic. And so this test is not performed.
Thank you for that. That sounds important. James, do you want to reflect on what you think are the most pressing ethical and policy issues from your perspective?
I think he touched a lot on it, but I just think the awareness, I think the most pressing thing is the awareness and having that access for patients who may be at risk for genetic disease. So just the lack of awareness, especially when it comes to African American communities, when it comes to hospitals, just not having the knowledge and not having the trust within the hospital. So I think that's definitely an issue, and who gets the test, and so I think it's important to continue to put the information out there for us to gain so that we can have access to different tests and understand what's going on. Fortunately, that sickle cell affects so many people. It is one of the things that's being tested for early on, because it affects mostly African Americans, and then it has a high number of 100,000 people. So they are screening for sickle cell, but I think across the board, you have to screen for all people and all things that may come up at within the newborn screening. And so I think the most pressing thing for me is the awareness that comes into play,
Yeah,
the
thanks
lack
for
of
that.
awareness.
Yeah. And I think one other question I have before we go to some of the people in the audience, and I can read their questions, is also thinking about the psychosocial benefits and potential risks of information that might come from screening or even testing. And I know that there's a history of this with newborn screening, partly in that, Dylan, to your point about needing some definition of treatable to be able to be included. Years ago, I was a guest on the Washington State newborn screening panel as they were considering adding something, and they were really focused on the magnitude of the benefit of the potential treatment or intervention that could be offered to people. So not just was there one, but was it likely to be effective, and what would be the impact in terms of quality of life or other measures. And, obviously we are very excited about the ways in which these tests provide answers and guidance for people who have conditions, their families and their clinicians, but there's a substantial group of people with diseases who don't get a diagnosis from these tests, or may, James, to your point, go through clinical care and hospitalizations without actually knowing what's wrong with them for a long time if they don't have access to the kinds of programs that Stephen's been saying we need to make more available in more states. So I was wondering if any of you wanted to comment on, what we do for the people who can't get answers, and what do we do when we have maybe some interventions to offer, but they may not be available to everyone, both because of reimbursement or because, as you said, Stephen, they don't live near an academic medical center. So I was wondering if anyone wanted to comment on that.
Well, I mean, it's our mission to fix this, right? That's why an organization like ours exists. It's to try to create solutions, to create awareness, to help elevate this so that people realize this is not okay. We do need to fix this. We need practical solutions. And then to think through what strategies and approaches are going to be effective. And we are making progress. I wish it was a lot faster, though.
Yeah.
I don't think there are magical solutions. I think this requires strong evidence generation. It requires a lot of advocacy and relentless pressure on decision makers so that we keep this high on their agenda.
Yeah. James or Dylan, do you want to comment on that, or on what we do for the people who can't access the benefits or who don't get a diagnosis?
Yeah, I'm happy to jump in. I think in terms of access, that's something that we also work a lot on, and it's ensuring the fact that so many within the rare community don't have an FDA-approved treatment or have a care standard, and for those who do, we don't want access to be essentially we don't want to put the treatment behind a glass wall that they can't get to, and so we're always working towards that end to how can we ensure better access. And so a lot of that is payer engagement and working with insurance companies for them to understand why there's some higher costs. So especially within rare diseases, with the new influx of cell and gene therapies that typically have a higher list price. So education as to why that is, and working there as we can. And I think also it leads me a little bit into answering another question that was in there that talked about age of onset and how that impacts newborn screening. And I think this kind of plays a role in this. Generally right now, the idea around newborn screening is a little less around onset and a little more around is asymptomatic treatment important? So the example for Duchenne is a great one, because Duchenne currently actually is on a few state newborn screening panels, even though the current age of onset may be around 5 years of age. the idea is the condition is generated by nature, and if you begin treatment as soon as possible, that will have an impact on the individual. The larger question will be, okay, that's a little easier when age of onset's 3 to 5 years of age. It's a little harder when the age of onset might be 25 to 30 years of age. So I think that's a gray. Between that is a bit of a gray area. But as of right now, age of onset is discussed, but not necessarily as important as the impact of asymptomatic treatment. What they do want to ensure the fact is that asymptomatic treatment is the key, not just waiting until symptoms arise and then you can go through the diagnostics process.
Yeah, and that relates to one of the questions that we had in the Q&A about, and DMD was used as an example by the questioner, but also for other conditions, whether the age of onset and the potential age of beneficial treatment or actionability should affect the ethics or policy around screening and testing. And I think what I hear you saying is it's more about the treatment and actionability and less about the age of onset from most of the discussions that you have. On the other hand, we're not screening for MEN2 thyroid cancer, which is highly treatable. We don't give people currently a package of all of the potentially highly actionable and treatable results that they might have in their lifetimes, right? So the policy, the state-sponsored funded policies for screening are more focused on childhood conditions that are childhood or adolescence, early adulthood conditions that are actionable or treatable.
Yep.
Is that correct?
And yeah, one something you said kind of formed it nicely in my head. It really, they more look at age of impact as opposed to age of onset. And I think the idea, again, if you can make an impact at 2-3 months of age, that's what they care more about. If the onset of symptoms would have been 5 years of age, that's a little less important. If the onset of impact of treatment would be early treatment. But yes, the idea of there. So in this conversation, I will say on the ethical side of it all, there's been a lot of questions around patients in waiting and what that does. What is the impact of that, of providing an early diagnosis and say, you may not need this information for the 20 years. What does that do? What is the impact? And there's some studies around that. Dr. Beth Torini's leading less around patients in waiting, but more around some of that work. But you're starting to see more of those studies in terms of age of onset, later ages of onset in relation to newborn screening.
Or variable penetrance or unknown variants with unknown significance, right? The cystic fibrosis has had some of this where there are variants, and certainly cancer as well, where we may not know if they're going to actually be disease causing, but they might be, and they may be so rare that we don't know enough about them yet to really give people a clear idea. One of our other questioners was talking about the RUSP, dovetailing to this, Dylan, that, do you think the requirement of available effective treatment should remain? There seems to be tremendous value in knowing a diagnosis early so you can connect with that rare disease community, regardless of whether there's a treatment available. So I have thoughts about that, but Dylan, maybe you want to explain why the potential benefit of community connection or other connections hasn't been a typical driving policy factor for thinking about adding things to the panel.
Yeah, so it's also important to note these are the core of the ethical standards was from the 1960s. They were updated in the early 2000s, but even then, that's still long before what we now view as modern medicine. It had been viewed, newborn screening had been viewed through ethical standards solely for the newborn and can you provide treatment. It had not been necessarily viewed as community. And in terms of long-term, the impact of providing diagnosis without a treatment available, it's a bit of a cop-out answer, and I apologize for that, but I don't know if we just have enough information quite yet, because I've had a little additional background on my background. I've been at EveryLife Foundation for 5 years. I started as a newborn screening policy fellow, so I've been working on this for many years, and so this is something that's been coming up time and time again. And out of my own curiosity, I ask people in my life, and there's some people who say, like, yes, I want that information. There are people who are like, no, if you can't help me, I don't want to know.
Yeah.
We can have differing opinions on whether or not that's right or wrong, but I think we need to have a better idea on a broader scale. How do people feel about that? Because there's an option of it's always important to remember with newborn screening, it is a mandatory test. And if it's mandatory, what extra precautions need to be taken because that is a mandatory nature. And to the question in the Q&A, maybe because of that, and if there's a high enough percentage of individuals who don't want that information, maybe it then becomes, okay, an optional additional screen that's stated, there is no treatment available for these conditions, and you can opt in. It could be it. And so it's like questions like that, and do we want to know about that? And I don't have the numbers off the top of my head, but Dr. Wasserstein at Screen Plus has some really great data around this.
Yeah, thank you for that. And per some of the data that Stephen shared too, I think, when a child is sick, having the information can be of greater value, and that's less of while that could be used for screening, it's also used in diagnosis sometimes in a hospital or NICU setting when a baby is sick and comes in and we don't know why, like the example that was shared. I think the other thing that I want to just, James, I'm going to come to you in a second. I'm not forgetting you, but I think the other thing I want to underline is there's also a question about whether or not the availability of gene therapy clinical trials should be considered a potential treatment to expand the panel. And someone mentioned that the FDA is hosting a listening session today about considerations for early enrollment. I think one of the challenges that maybe, Stephen, you can mention briefly, or Dylan, is that adding a test, the way the tests are currently done for newborn screening specifically, so not the genome sequencing screening that you're studying and that your paper's coming out, Dr. Kingsmore, but doing the newborn screening the way we do it is funded by the state and has significant costs to add a test. It's not just looking for, right now, it's not just looking for a different piece of information on the same test. So I don't know if someone wanted to comment on that or clarify that. I don't know, Dylan, if you want to say sort of what the barriers of cost sometimes are to adding something to the newborn screening panel when the benefit is, I think Dr. Kingsmore talked about avoiding, and you did too, Dylan, avoiding a diagnostic odyssey that might include out-of-state trips and other kinds of things that are expensive, but that the value of networking and being in clinical trials is maybe a different value than treatability. Do you want to talk about that?
Sure, and just to clarify, in terms of cost, are you talking about cost to the lab or cost to the family?
Cost to the state of adding something to the panel.
So there's just not enough money in newborn screening, and that's the easiest way to put it. So actual testing on the metabolic side, the actual cost of running these conditions are not that high. Adding them can be the challenge, and more often than not, it's buying a new machine or hiring a new staffer is really the challenge there. Some of the challenges around overall cost of the state in terms of wanting to say to the state, this all comes from the same money. You might spend a little more in the public health lab, but you're going to save money in the Medicaid side. Gets complicated for a very frustrating bureaucratic reason, in that most states' Medicaid programs need to be as close to cost neutral in a single year period. These cost savings are over years of life. So you might have that initial high treatment cost, and over 15 years, the state will save money. Over 7 years, maybe not. Definitely not in 1 year. And so that's where some of the challenges are. It can be extremely frustrating. And then you have states, this also impacts newborn screening, where will say, well, what happens if the individual moves? I'll get the cost savings. I'll get the burn of the cost savings, but then if they move to the neighboring state, that state gets the cost save. Which, when you're trying to balance a budget, it's a frustratingly understandable comment. And so that's some of the issues where it's hard to get the government to look at its full budget in a broad picture, even though we know there is data out there that shows if you spend some money on the front end, you'll save money on the back end.
James, I want to come back to you because I think sickle cell, you were mentioning that you were born at a time when sickle cell screening was not standard. It is now, but you've also talked about having a diagnosis hasn't necessarily led to easier treatment. Now there are starting to be some potential gene therapies available for sickle cell. I wonder if you can talk about what you think some of the challenges of making the benefits available to everybody from screening and diagnosis can be from your lens as a patient.
For gene therapy.
Yeah, for gene
Or
therapy
just,
or just any kind of therapy, like just saying you have sickle cell. I think you wrote about this in your book and you mentioned it
yeah.
in your talk. When you tell doctors that, that didn't translate to them understanding that you needed morphine for your sickle cell crisis, for example.
Yeah, so I'll say that first off, the when it comes to having therapies, the cost has to be lower for patients. So that's one thing that people look at immediately is the cost of how can I afford this? So if you don't have anybody to cover that or explain, that they will be covered, then you have patients who won't go into it because of the cost of it, the therapies and the medications. But also having to explain to doctors who are not knowledgeable what sickle cell was, it's frustrating for the patient to have that diagnosis and come into a clinic and for me to have to explain to them what I'm going through or explain them to do certain tests. It's frustrating as a patient. You want to have trust in that provider. You want to have trust in the system that they understand and know what sickle cell is when you come there having this rare disease, because you can't treat it on your own. So you look for others to help you in that process. And so when you have to continue to explain, it's very tough and very frustrating. So I think just continuing to advocate and have access to treatments or have people who understand it is very important. And that part piece comes into legislation and continue to advocate to get these models in place so that we can have more knowledgeable doctors, we can have more therapies, we can have resources for people with sickle cell, because you don't want to have no resources to turn to when you're dealing with a rare disease. And just to bring up, you know, another story, I have a friend, her son just got is diagnosed with Batten disease. For years, she didn't know what he was going through, and she didn't know, there's not a whole lot of people diagnosed with Batten, so she feels lost and she feels scared, and that's the thing, and that's why it's important to have a community, have some people we can advocate for and get early diagnosis so that you can find others going through it and get some relief, because no one knows what it's like to be a caregiver. I don't know how my parents felt, but I know that they didn't know what I was going through, and every year I got older, they had to learn more. It was something new. So, just having a diagnosis in itself is not enough. It's having the education to go along with that diagnosis.
Yeah,
And that's important.
that's such a good point. Thank you. And one of the other people wrote a question saying, your story about bias and frequent flying is not uncommon. Wondering if you've noticed any improvement in this context for sickle cell disease patients since you were diagnosed, or things that worked for you or people you know through your advocacy work around that, or lessons people can take from that.
Well, the thing that helps me is I learned my body. So I had to take an understanding of what I was going through, learn that eating healthy and um, you know, exercise. And I learned that helped my body. So that helps me stay away from it. But I also had some therapies that helped me. The thing is, if you have one therapy on the market, it may help me, but it's not going to help the other person. And so that's why it's important to have more. But this therapy helped me. And so not being in the hospital constantly where I can go months or years without having a crisis helps me when I go in and see the doctor. For someone who's the disease manifests differently and they have more crisis because it can't happen, then they're the ones that still continue to get flagged for going to the hospital so often, and it hurts them. And that's just the stigma that we face. Um, and with gene therapy and other therapies coming out, I think it's even more important to advocate, like what we go through, and we need the help of the medical system, because they think sickle cell is cured, but not everybody will have that cure. And so the people who don't have the cure or the therapies don't help, then they're going to be the ones that's still in the hospital. And so I think
Right.
it's important.
Yeah, I think I'm really glad you said that because I think there's things about treatment and lifelong treatment that exist even when we have the best proven FDA approved treatments that work for the most possible people. There will still be some people for whom that's not available. Hopefully not because of insurance, but right now that may be true. But also, again, with gene therapy, there's some people who are not eligible because they have antibodies to the mechanism that delivers it or other kinds of things. So we will always need to think about how we can provide better care, more sensitive care to people who may not be able to benefit from therapies even when those exist. So I'm really glad you mentioned that. Stephen, so there's a couple of questions about genome-based newborn screening, and you mentioned this about why it might not fly or why there's pushback from parents. And the person asks, is this mostly an informed consent issue or others? Are there other policy and ethical barriers to making genome-based newborn screening more of a reality? I wonder if you could comment on that.
Yeah, sure. Yeah, I saw that question. Thanks for asking it. I might have misspoken there. I actually firmly believe that genome-based newborn screening will fly. It's not going to happen this year or next year. That we need to do a lot more research to understand it better, to build the evidence base, and to navigate a whole bunch of issues related to implementation. It's very, very different than standard newborn screening. And we really have to carefully, once we have the evidence, which is forthcoming, that says, yes, this is useful, this will benefit our population, we then will need to move into, okay, how are we going to implement this? Is this something that we place in the public health system? Is it an extension of current newborn screening? Or is it a separate entity? There are so many questions. And right now, we do newborn screening, obviously, at birth with a heel prick. And as we've mentioned here today, we are now starting to look for conditions that don't have onset until later in childhood, like Duchenne muscular dystrophy. And so this is another part of the puzzle is, do we limit population screening for genetic tests to a baby? If we're going to get informed consent, that's probably the most difficult time to actually obtain it is when a mom or a dad are just, in the process or have delivered a baby. They have a lot on their mind, and one of the things is not providing consent for a complicated test. Why not wait and do this at well baby visits? And for conditions that don't have an immediate onset, think about the timing of it. So I think there are many, many, many questions, but I do believe that genome-based newborn screening will happen. There are many trends that favor it. One of them is gene therapy. Let's face it, one of the biggest challenges for any orphan drug manufacturer is, I finally get FDA approval for this miraculous curative therapy, and I can't find any patients to give it to. So we absolutely have to think through how we can solve for that so that our population gets the benefits of these amazing new genetic therapies.
Yeah, I think that's really interesting and important. And then, as I said, I gave the example of MEN2 thyroid cancer, for which the recommended prevention is a thyroidectomy, but not necessarily in early childhood. And so how do you explain those? If you're going to do genome screening, you'll find those things too. And are you going to offer those to people? And how are you going to explain that to people for planning? And then also implications for parents too. You may find something that's relevant to the parents in the child if you do genome screening in children. So that's very interesting. Thank you. Going back to James for 1 second, there's an interesting question about hearing from parents with kids with rare disease. They have a lot of fatigue from having to explain their kid's condition to every single provider. And also that those that have insurance can't always afford the therapies, and those without insurance often can't afford to pay out of pocket for things that may help. Although in our state, I will say sometimes some therapies are actually more available for children on Medicaid than for private insurance. And as you mentioned about loss of income and your own family's experience and your mother having to be the caregiver. I'm wondering if you could talk a little bit about what we can do to support parents, even if we do succeed in identifying and diagnosing people earlier through screening and hopefully getting them access to therapies. How can we support parents like your parents and some of the other parents that you advocate for and with?
First off, listening to the parent, asking what they need. That's the biggest question. A lot of times we can provide something, but we don't know if that's necessarily what they need. So asking directly the parent, what would they need? But I feel like resources, having information, resources, being a community that they can come to and talk to, is a good way to help parents. And just continue to be supportive. You can also advocate with the parents or advocate for that child who has sickle cell or whatever rare disease they may be going through, but just being that emotional support, because parents feel drained out. Like you said, the fatigue is real. They don't know where to turn to, and they may be dealing with something that nobody else understands. So just having that emotional support for that parent, and having a listening ear, and coming to that parent and asking exactly, what do you need help with? How can I help you? But I think overall, providing resources, um, resources help a lot. My family didn't have transportation. Having transportation to get to the hospital was important when I had those appointments when I was a kid. So, transportation was provided. So a lot of different things can help a parent that you may consider to be small, but it would definitely help out if you just ask and become a part of that community, and share, let them know that you're there to help, and lend that emotional support and that support. And if you're not a provider, but you, you know
And humility, I think that's the other thing I
humility.
see
Yes.
with doctors is like, doctors know, and healthcare providers know a lot, but they don't know everything. They don't remember. It's not possible to remember everything they've ever been taught. And
Mhm.
so expressing humility and then also realizing that I do this in some of my clinical ethics work too, that when someone's in the hospital with their child or their family member and they're very sick or they're in pain, especially if they don't know why, or there's not a clear treatment, or the treatment's not working, it's probably one of the worst days of their lives. And they may not
Mhm.
be totally presenting their best, most rested, most thoughtful selves. I certainly haven't as a parent bringing my child to the hospital. So, I think also expressing empathy for the fact that it can be a very hard journey for people, right?
Yeah.
I'm sure it was for your parents too. Somebody raised a really good question about that, in a perfect world, early diagnosis of a genetic condition is the only information that enables earlier treatment or research participation. But that perfect world also means there's no discrimination for healthcare insurance coverage. Often ACA covers things now, but that might be at risk if it's repealed. What do you guys think about the political landscape around limited reimbursement for available diagnoses, genetic diagnoses, and how that might or might not inform policy decisions? Dylan, I'll start with you since you've been thinking about a lot of this from the policy lens.
Yeah, I'm so in terms of reimbursement, I'm having a tough time answering this question because I want it to be two different situations where we should screen and we should use the tests that work best, and then let sort out the reimbursement side of it second. But that's not the world we live in. Um, and so I think what helps, I think it's less of a policy situation and more of we need more data, because you'll see higher reimbursements, you'll see better coverage when payers see the data that they feel that they need to cover these tests.
Right.
And so unfortunately, that creates a chicken or egg situation where you can't get the data if there isn't higher reimbursement, and so on and so forth. But for me, I think it's one of those things where you engage more with the payers and kind of bring the data to them and say, like, this is why we need better reimbursement on this.
Mm. And just briefly, Stephen and James, do you want to add anything about the policy landscape with variability and reimbursement for treatment? Or uncertainty about reimbursement? I know it's tough and tough.
Yeah. What was the
Well, if
exact?
people can't get access, if insurance coverage is unpredictable and uncertain, and people are not able now even to get access for some treatments, and then that might be even more at risk in the future if certain things like the ACA are repealed, does that change whether we should screen if we can't be sure that all people can get access to the treatments?
No, I don't believe that should change. I think people should have the opportunity to get screened. I think it's important, and it, like I said, it helps the family out. It provides relief, and I just think it's important that people have a knowing what they're going to face if they have someone with a rare disease coming into the world, and it helps the family prepare better and you know, find other resources that they can have and help out.
Yeah. Great. Well, with that, I think we're pretty close to the end. I want to thank our panelists and then pass the mic back to Aiden, who I know is putting a lot of important things in the chat. Aiden, do you want to take over with the closing remarks?
Thanks so much. I'm just gonna share my screen really quickly here. All right, so as Holly said, we're running out of time. I just want to take a quick minute to thank all of our panelists for such a great discussion today and all of our attendees for your thoughtful questions. We really had an active and great Q&A today, so thank you for that. And be sure to tune in for tomorrow's panel. I put a link to register for that in the chat. It's on the topic of long-term follow-up and co-hosted by the MRCT Center. On behalf of PGTME, I would also like to thank all who have attended, participated, or helped put this webinar together. I'd also like to remind you that PGTME exists courtesy of charitable donations, and if you are interested in supporting our educational initiatives, please contact our co-chair, whose name and email address have been shared in the chat. And with that, thank you so much for attending and have a great rest of your day, and thank you to all of our panelists again.